All right, we're going to shift gears a little bit for the last talk of the morning. Dr. Mary Dolan brings us our final lecture today. Please sit tight at the end of this lecture. We're going to have a quick business meeting, and also we have a special guest that's going to join us for a special message. Dr. Dolan is a professor and director of midlife and menopausal medicine at Emory University's Department of Gynecology and Obstetrics. She earned her undergraduate degree from Duke University, her Master of Public Health and Doctorate of Medicine from Emory University, and completed her residency at the University of North Carolina. Dr. Dolan has served as an epidemic intelligence officer at the CDC, helped establish the Harriet Tubman Women's Clinic, and is actively involved in mentoring and career counseling at Emory School of Medicine. She was inducted into AOA as a faculty member in 2016 for her dedication to professional excellence, mentorship, and service. She works at the Emory School of Medicine as a small group advisor, is director of the Women's Reproductive Health Module, and is director of career counseling at Emory. Please welcome Dr. Mary Dolan as she presents Menopause and Hormone Therapy, an update for 2024.
So I have to stay here? Okay, all right, cool. So thank you guys for, thank you so much for the invitation to be here. Thanks to Dr. Green, the planners, Nicole Reeves, all the people that put this together. I really appreciate the opportunity to come and spend some time with you today. If this was the reproductive lifespan, this would be menopause, you know, for the morning. So this is your menopause part of the morning. Let's see, let me go ahead and get started. So, is that one going? Oh, wait a minute. There we go. Nothing to declare. Also, I do want to point out that certainly we want to support gender diversity, and I realize that not all persons experiencing menopause may be identified as female. However, for the talk, that's the pronouns that I'll be using, and that's how I'll be referring to patients. All right, we've got some objectives up here. And, you know, menopause, similar to the OB and cardiology spectrum of things, has definitely gotten a lot more press lately. Part of that, I think, has come from the public pushing on wanting more information. And this article, I don't know if anybody saw the article last year, New York Times, but it really kind of set off a lot of frenzy among, you know, with our information age, people pushing like, why aren't our doctors telling us more and speaking about more options with menopause? Anybody see the article? A few people? Yeah. I mean, I'm sure you heard about it. If you take care of menopausal patients in your clinic, again, this kind of set off a lot of craziness, but I think rightfully so. So I think we haven't really given menopause the attention that it's needed, and particularly in our specialty as well. So is this a public health crisis or not? What do you guys think? I mean, we're living longer. We know women live longer than men. But do you want to have a longer lifespan, or do you want to have a longer health span? So you got to think about that. So since women live, you know, a good part of their life after menopause, we have to kind of really think about, are we doing the best thing for them? What are in these options for treatment of their symptomatology, of their distress, and also more and more we're finding out benefits of hormone replacement therapy and other treatment options. So if we've got this increasing awareness of the impact of the symptoms in midlife, we've had kind of more outcry, there's more communication on the web and podcasts. I'm sure people have heard their patients talk about different podcasts on menopause and sex. Then why aren't we offering this care? Why aren't we up to date on this? Well, a big, huge problem is that we're not educating our residents. So this was a survey from 2022 of all of the OBGYN residency programs, and really only 31% had menopause curriculum, which was mostly just, you know, here, read this lecture, or have this assigned reading. And then most people don't spend time in menopause clinics or working with providers that specialize in menopause. Now, also, the providers that are working in menopause, they also may not have had the education because there's been so much misperception about how the studies on menopause, starting with the Women's Health Initiative, have been communicated to the public. So, and I'll say, you know, even Emory, we're guilty of this with the requirements for ACGME and needing more surgery experience. You know, I used to have residents rotate in clinic with me, and now I don't have residents anymore because they get called to the OR. So then they call me when they get out and I've practiced, and they're like, okay, what should I do with this patient? So anyway. Furthermore, we know that there are disparities in when women experience menopause. This is just general definitions, and I know you guys all know this, but about 5% of women will experience early menopause. And if we know that loss of ovarian function is associated with increased morbidity and kind of decreased quality of life, increased risk factors for dementia, cardiovascular disease, and all of this, then the earlier that you have that loss of function, the more at risk you are. And there's disparities between Black and Hispanic women as well, having earlier menopause, and across different countries. For instance, the mean age of menopause in the US is 51, and it's 46 in India. So why do these discrepancies happen? That's not been well studied. Why does menopause happen? Well, basically loss of ovarian function, and we've got loss of quality in the ovaries as well as loss of number. So, and interestingly, this is an area that is still poorly understood. You know, why, how, what are the cellular mechanisms for the loss of ovarian function? So I see a lot of menopausal patients and coming in to my clinic, and everybody wants to come in to get their hormones checked, right? Can you check my hormones and please tell me where I am? Or tell me if I'm in menopause. I think I'm in menopause. I've been in it for 10 years. So I use this little handout. I have it printed out in color, trying to kind of go through really what's going on hormonally and how sometimes, you know, just checking your hormones is not going to necessarily tell us where you are in menopause. It'll tell you where things are today. So the top graph is, you know, 6 months, and I say this is how everything is very well organized when things are regular, and then perimenopause can be, you know, just all over the place, and you can kind of vary between the two. You can early perimenopause kind of go back and forth. You might have a few regular months, and then you might have a few kind of crazy months. And most patients will look at this graph and say, that's exactly how I feel. You know, with my mood and everything else, and sleep, and sometimes it's good and sometimes it's not good. So this graphically kind of depicts an attempt to kind of define all the stages of reproductive aging, and this was put together, I think, in 2001, and then kind of redefined in 2011. And if you'll take a look, you know, just so really one of the earliest sign is just subtle changes in the menstrual cycle. Let's see, I don't know if I can work the pointer. Yeah. So, and then when the cycles start to vary more or less 7 days or more, then we think, okay, that is getting to early menopause. But they may not have symptoms then. They may have hot flashes, but the lab testing is not that helpful. So the point being here that really the menstrual history is the most important. If you look at kind of FSH levels across time, it's really not until at 2 years after the final menstrual period that the FSH really stabilizes. So I use this a lot in clinic, and you can download a lot of these resources free from the Menopause Society website. It's menopause.org. And if you go under kind of patient resources or publications, you can find lots of great information. So keeping track of the menstrual cycle is really one of the best things we can do to kind of tell patients kind of quote where they are. And I use this a lot also because it tells people what's not normal. So a lot of people may think, oh, it's just normal to have this irregular bleeding like this, and this is normal for menopause, but I think it's important to kind of look at things like this. And just like when you have patients with PMS or pain syndromes, keeping a diary is really helpful for checking to see if there's any relation to the hormonal fluctuations as well. Now, you might have heard of last year, the Clear Blue company came out with a menopause stage indicator. Anybody have any patients use these? Yes? Okay. So instead of, like the ovulation predictor, this measures FSH, and each box comes with a kit of 5 urine tests. And the idea is that it checks urine FSH, and you would check it every other day for a total of 10 days to try to kind of figure out where in that stage you are. So, this is available to give, if patients want to use this, but is it necessarily that helpful? Probably not, yeah. But, I think it gives patients a tool to feel like they're getting some information on what's going on with their bodies. All right, so I know this is a group of OBGYNs who are well aware of the cardinal signs of menopause, but I do want to point out ones that a lot of people don't think about. I mean, we always think about the hot flashes, night sweats, but increased anxiety and some mood changes can be really distressing to a lot of patients, and I don't think that that's kind of talked about as publicly. And in addition, there is now kind of described a, quote, musculoskeletal syndrome of menopause. So we know there are estrogen receptors in like every cell of the body, and some patients can come in with just, diffuse joint pain. So it's not uncommon to see patients that they'll start having the symptoms, palpitations, anxiety, joint pain, and those might even come on before they're having a lot of, night sweats or hot flashes, so they don't really identify it as perimenopause. They'll go to cardiology, have their workup, rheumatology, and then, months later kind of fall in, oh my gosh, put this together, that this could be related to hormonal changes. But importantly, there's lots of long-term consequences that occur. And so this is what I wanted to kind of focus on as well in terms of treatment options. Now, the weight gain, sometimes that's the number one, I see some nods, number one complaint. And interestingly, there is information showing that during perimenopause, there are changes. We don't really know kind of how to elucidate all this out, but that there is kind of steady weight gain in perimenopause, that after menopause, 2 years after, everything kind of settles out, that gets less. So I think that's reassuring to tell patients that also, if you're eating the same thing, you're exercising the same way, you're doing all the same stuff, and you're still gaining weight, that's a true phenomenon. But, you're going to get through it and get on the other side, and, you just have to kind of keep working to not gain as much and during this transition time. All right, trivia question. Anybody know what other mammals go through menopause? Elephant. That's usually what my students always say. I use this in my student lecture too. So it's not elephants. Huh? Sharks. No, it's not sharks. Apes. It's not apes. Dun da da. The most surprising slide of the day. It's actually toothed whales. And there are a couple of theories why this happens or why this is beneficial, and one of them is the so-called, quote, grandmother hypothesis, that these older women whales, they don't compete for, reproduction with the other males, and they help propagate their own DNA by taking care of the pods, knowing where the scarce food is, and kind of helping kind of their sons and their families. Anyway, and if anybody is really interested in women's kind of evolution, the book Eve, anybody read that? The book Eve by Kat Bohannon, which came out, I think, last year sometime. Eve, like Adam and Eve, EVE. I mean, it is totally fascinating. I bought the book to kind of listen because I'm in my car a lot. And then I ended up buying the book too because I was like, oh my gosh, I've got to look back at this. There's all this information about, trapdoor vaginas and ducts, and just the whole evolution of the uterus, and why certain species we had certain ways. Anyway, I think it's really entertaining, so I think you would enjoy it, being in women's health. Okay, so I've got a couple of cases, and we're going to talk about just some of the kind of salient features. Some of it is historical review, and then we're going to get into kind of newer therapies and what's on the horizon, possibly. So we have a patient. She's 54. She's having a lot of vasomotor symptoms, and we classify vasomotor symptoms by severity, usually if there's more than 7 or more per day, and if they interfere with her lifestyle or her quality of life. So her medical history is negative, and so she's sexually active. She doesn't need birth control, which is another thing to make sure your patients in perimenopause are also aware of, that they can get pregnant. I see the head's nodding there too. Don't want to have any oops babies there. So would you recommend hormone therapy for her? Anybody? Show of hands. Show of hands. So that's good. We've got a good group here. So just looking back, what is hormone therapy? We've come a long way, that we have lots of options now. We have transdermal, we have mist, we have patches, gels, we have oral, and we have some SERMs that we'll talk about in a minute. And we have kind of the, quote, bioidentical versions of these now available. So for years, it was only the conjugated equine estrogens that were used, and that was the estrogen that was primarily used in the Women's Health Initiative as well. So similar to your last lecture, just a little bit of digression back into kind of how hormones work. And just a reminder that we do have, different types of estrogen receptor alpha and beta, and there's progesterone and then progestins that act as progesterone-like, but they also crosstalk with androgens and glucocorticoid receptors, and certain progestins are, worse at doing this. So, for example, medroxyprogesterone acetate does more crosstalk with these androgen and glucocorticoid receptors and increases things like insulin resistance or IGF-1. So the type of progestin or progesterone that you use with the hormone therapy does matter. And I think many of you probably know of this because of the different variety of birth control pills that are available. And really the estrogen component in birth control pills is pretty much the same of most of them. And then it's just the progesterone that varies. And then classically, hormone is absorbed, goes to the nucleus, and affects transcription. And this is even more complex too. I mean, there are, let me go back, probably receptors, the cytoplasmic receptors versus the nuclear receptors. So when we get into a little bit more stuff coming up with the new estrogen, estetrol. I don't know if you guys have heard of that estrogen, but it kind of has a little bit different mechanism of action and possibly affects kind of the cytoplasmic receptors. All right. I probably just sat somebody too, pushing the wrong green button here. This is just an old study, just originally, showing that, there we go, that estrogen is very effective for treating hot flashes over time, and there's a dose-related effect of this. But not as commonly known is, kind of how long the hot flashes or vasomotor symptoms last, and that they can vary by different factors, such as if you start having hot flashes earlier, kind of premenopausally, that a higher percentage of women will continue to have those several years later, versus if you start having vasomotor symptoms later. In addition, there are ethnic and race variations, and African American women tend to have hot flashes longer. So the mean time of hot flashes for general population around 7.4 years, and white population maybe 6 years, and African American maybe 10 years. So, and then hot flashes can continue on kind of forever. Usually the intensity does go down over time, but I think when I was training and going through medical school, it's like, just grin and bear it. The hot flashes, they'll be gone. It'll only be a few years. Just get a fan or some of those sprays or whatever, and sleep with peas in your pillow or something. I don't know, frozen peas. But we know a bit more now that this isn't true, that they can be very disturbing. Before prescribing hormone therapy, we always want to think about any contraindications. I know you guys are aware of all those. And then she had a family history. Does that affect whether we use it or not? I mean, you heard a whole lecture before me on cardiovascular risk factors and stuff. And we know that, that was in pregnancy, but that cardioprotection is kind of lost after menopause, and there's lipid changes and remodeling of the endovascular system that can occur without hormone therapy. But we do know from lots and lots of studies that if you have heart disease, that hormone therapy can be dangerous. So there are several trials that looked at use of hormone therapy for secondary prevention, and these all were like, nope, you have a higher incidence of cardiovascular risk, so not recommended there. And then the Cardinal study, Women's Health Initiative, was designed to look at primary prevention of cardiovascular disease, and was a very large randomized trial. Emory was a center. And in fact, I actually worked with the center as the gynecologic consultant and took out IUDs and all this, and all these 75-year-old women, and Lippy's loops, and all these things that people just never came, whatever they had abnormal bleeding, basically, they sent them to me. And I wasn't involved in the design of the trial or anything like that, but it was fun times working with the patients. Let's move on. And the trial was stopped early. You guys know about this because of the reporting of increased risk of breast cancer. And, this whole debacle of the reporting of this trial and not speaking with the investigators and the data safety monitoring group, reported this, and the public went kind of crazy. And in a day, before that, maybe 60% of patients, 60-70% were using hormone therapy, and by later that year, it had dropped to probably less than 10%, and then kind of has stayed like that. And then in addition, the education stopped after that too, because it was like, oh, it's just bad, we don't need to teach about that anymore. But the things that weren't reported was there, in the estrogen-only side of things looked more beneficial for breast cancer. And then when they re-looked at the data, they looked back, and it looked like that really when you started hormone therapy was more important than kind of what you were taking. And this is kind of just a summary slide of all of the kind of outcomes, and looking at, DVT, certainly these risks were increased for, this is the estrogen and progesterone, and this is the estrogen-only side of things. But really, looking back, the death from all cause was really reduced for both groups, which was fascinating, right? I mean, this part was never reported, so this didn't get the big press of anything as well. From the reanalysis, the timing hypothesis was hypothesized. So because the mean age in the Women's Health Initiative of women was 63, they were greater than 10 years post-menopause, so they looked back, and basically, if you started hormone therapy closer to the age of menopause, it looked like there might have been benefit. So there were some studies that went to look at this, and we have the ELITE trial, which is one that used carotid intimal thickness as a proxy for coronary artery buildup, and it showed that it looked like that earlier atherosclerosis or earlier heart disease possibly could be prevented with earlier use of hormone therapy. So their trial looked also at a different estrogen. It wasn't conjugated estrogen, and I think they used vaginal progesterone. So you get kind of two things coming out. One is that the progesterone was kind of the bad guy, so let's figure out what to do about that. And the other was, well, maybe conjugated estrogen is worse than estradiol. So these are kind of two themes that we'll see over the next, 10 to 15 years, and kind of what the studies then started to look at, but there'll never be a trial, I don't think, as big as the Women's Health Initiative looking for primary prevention. So conclusions here was that, it shouldn't be used for primary prevention. You may have increased risk of strokes, and it may help if it started basically earlier, closer to menopause, when you have symptomatology, when you start hormone therapy. And I do definitely recommend risk assessment prior to starting hormone therapy, and frequently work with our Women's Heart program in terms of evaluation. All right, so moving on to really the second problem that a lot of patients have concern about are kind of cognitive changes. So we have a patient, she has a Mirena IUD, which Mirena IUDs and progesterone IUDs, are awesome, right, for perimenopause, because they can help prevent the abnormal bleeding or regular bleeding that occur. They give you birth control, and off-label use. I definitely use them for kind of the perimenopausal transition. And in some postmenopausal patients, also off-label for endometrial protection, if they don't have a tolerance to progesterone or particularly don't want to use progesterone. But anyways, she is concerned about her brain fog. She's not functioning well. She's got family history of Alzheimer's, dementia, and so she's worried about her breast cancer risk because she's never had children. So would you want to give her hormone therapy? Still a pretty good, maybe 50%. Yeah, we'll try it. Well, first off, too, there's no harm. A lot of times patients come in and like, oh my gosh, it's like a life or death situation. Should I take hormone therapy or not? And there's no problem in, trying it. I'm not saying that you're going to be on this for the rest of your life. If you don't want to be, that hormone therapy is really something that we kind of address annually. And I tell patients also, this is a point where we're looking at your aging process. And so how you age, your lifestyle changes that you make now are super, super important. I think that's really missed, that you have the weight gain. We know that you're going to have loss of muscle with time. And so developing those good habits now can really help you. If you want to be on hormone therapy when you're 90, then you've got to start doing those things now. So, all right. So does hormone therapy help cognition? So this is where it's a little bit more mixed. There are some studies that say, well, neutral. Some studies says it doesn't change it at all. A few have said it makes it worse. But if the patient is having very severe vasomotor symptoms and not sleeping well and all of that, then certainly treating those symptoms with improving your sleep can definitely affect cognition. And another interesting finding is that also during perimenopause, for reasons that are unknown, similar to kind of the weight gain phenomenon, there can be changes in cognition with aging that is worse during that time and then does get better afterwards, although many patients don't feel like it's totally back to the way it was when they were premenopausal. So, I like to tell patients that too, because they feel like they're going to go crazy, and whether I do or don't take hormone therapy, that some of this will get better with time. Validation of their symptomatology, telling them it won't be like this forever, all those things are also important, just kind of counseling tactics, because women feel very unheard and not validated for the symptomatology that they're having. All right, so what about risk of Alzheimer's? Similarly, we know if patients have their ovaries out earlier or have POI, they're definitely recommended to use hormone therapy for prevention of Alzheimer's disease. That has been shown that there's a really increased risk of Alzheimer's, when you have early oophorectomy. And so, again, there are a few studies that support kind of the timing hypothesis with this. There are some mixed data. I think there was another Danish study that looked at risk of Alzheimer's, and I think they didn't control for other risk factors that were going on for Alzheimer's, such as decreased education and other lifestyle factors and all of that. But it kind of makes sense. I mean, if we think that hormone therapy affects the vasculature and affects, that would be the brain vasculature, just like the heart vasculature. So that's still not totally sorted out, but probably helpful. And then what about the breast cancer risk? So, this is the patient's biggest worry, and they don't worry about the heart disease or the osteoporosis or the things that they can't feel. They worry about the breast cancer because this gets kind of the attention in the press and all of that. And breast cancer risk, we do know, goes up with aging. And there are several other lifestyle factors that people don't like to be reminded of, such as regular exercise, weight loss. I mean, I can't tell you how many patients have that are obese or more, and I'm so scared about this. Well, your weight is really probably the most important thing that we need to think about right now. That really increases your risk of breast cancer, and that's just kind of like a symptom that, or people are unaware of that is associated. Alcohol consumption, more than one alcoholic drink per night, can be associated with increased breast cancer risk. So all of these things, I think, is an opportunity to speak with them about alternatives, to lower their breast cancer risk as well. And we don't think that hormone therapy causes breast cancer. When you have the cellular changes that are leading to breast cancer, certainly the hormone therapy can kind of fuel that fire or increase with receptor positive. But many studies looking at breast cancer mortality show that patients that have used hormone therapy in the past have a lower breast mortality, all-cause mortality, than patients who get breast cancer who haven't used hormone therapy. So really, hormone therapy may be the only drug to decrease breast cancer, quote, mortality. Now, we're talking about recurrence of breast cancer and all of that. I mean, many patients don't, quote, die of breast cancer if it's caught early as well. So we have to think about kind of that longevity of the patient. And in fact, there's some thought about maybe hormone therapy being used in breast cancer patients. So once they're caught early. So, yeah. All right. So moving on to some of the other questions that we have, so how long is it safe to use hormone therapy? And what's the best hormone therapy to use? Like, what should it be oral? Should it be transdermal? So this was a recent report using Medicare data from 2007 to 2020, and over 10 million senior women. I mean, great big, huge study. It was an observational study, but then looking at the outcomes for all-cause mortality, 5 cancers, I think it's breast, lung, ovarian, colon, and one more. Anyway, and then cardiovascular diseases such as, congestive heart failure, acute MI, atrial fibrillation, et cetera, VTE, and also dementia. So let's see. So the key findings there, and this was in the group that used estrogen only, and they also kind of sorted by different types of estrogen. So, and whether it was estrogen progestin, whether it was estradiol, progesterone. I mean, there were several different ways that they could look at this because they had the prescription data. All right, so they had prescription data, they had the outcomes data from, from all their Medicare information. So there were significant reductions in mortality for breast cancer, lung cancer, colorectal cancer, congestive heart failure, VTE, AFib, acute MI, and dementia. So that was good news. Bad news, whether you used a progestin or progesterone, there was a slight increase in breast cancer risk. So here we are thinking again, okay, the progesterone is the bad guy. So what can we do about that? The other thing is the patients with estrogen and progesterone did have decreased endometrial cancer risk and ovarian cancer risk. And there was a reduction in congestive heart failure if it was estrogen and progesterone. So progestin would be like the synthetic progestins in the study, and then progesterone would be like the micronized progesterone. All right, and this was their conclusion. So so the possibility of the health benefits of using this past 65 years, because it used to be that the Beers criteria would say, after age 65, people shouldn't use hormone therapy. And then Medicare wasn't going to pay for hormone therapy after age 65. And so I think, this is a great stride to show that that's not true. The other thing in this is that vaginal estrogen was not associated with any increased risks, and we do know that vaginal estrogen is very helpful for the treatment of the genitourinary syndrome and menopause. And we know, the safety, everybody always says, well, what's the safety data? It's only been shown for a year, but I think with the results of this study, we can say that it can be used safely, and the vaginal use was not associated with increased risk. That's probably, I think all the other things are great outcomes, and they give us fuel to our armamentarium to say, well, okay, if you're over 65 and you want to keep using hormone therapy, that's okay. And certainly in patients, again, that are having vaginal or genitourinary symptoms, that vaginal use can be used safely. So just to remind you, what are the FDA-approved indications for hormone therapy? So we've talked about moderate to severe vasomotor symptoms, prevention of osteoporosis. So, patients come perimenopausally, and this is not something that they're thinking about. And then when they say, well, what are the recommendations? When should I get a bone density scan? So, the recommendations are age 65. I'm like, well, if you wait till age 65, the cat's out of the bag. So we got to kind of go ahead and think about getting imaging sooner. And certainly menopause is a risk factor for osteoporosis. So I'll usually get that sooner, because if you're trying to kind of figure out what's in the good side for me to take this therapy, what's in the negative side, that preventing osteoporosis or protecting your bones is pretty important for kind of your health span. All right, so I'm going to move into a few of the alternatives, and these are really, really interesting. We do know so basidoxifene, interesting drug, it's a SERM, and it is available in other countries as a separate medication because it has been shown to decrease osteoporosis, treat osteoporosis, and reduce fracture risk. But here in the US, it's available only in one combination with conjugated equine estrogens. And so this takes, remember we talked about progesterone being kind of the bad guy. So now we have an option where we have medication where you can give this without using the progesterone, without the bad guy. And so it is approved for treatment of vasomotor symptoms, and there's been studies on this. And again, oops, let me back it up again. So vasodoxifene alone has been shown to really treat the bones, okay? Now, it does have a slight increased risk of VTE. So if you have a patient that's high risk for VTE, would not recommend vasodoxifene for that. And then these are two more recent studies as well, just looking at, okay, so we think progesterone might be the bad guy in the breast, and so now the perfect SERM would be one that could protect the uterus, we could protect the bones, we could not cause harm in the heart, let the estrogen do that, and prevent breast cancer. So it's not been shown to, quote, prevent breast cancer, but it has kind of anti-estrogenic effect on the breast, which is favorable. And in patients that have dense breast, I think that's everybody that gets a mammogram now. I mean, all my patients come in now because they changed the way they report it, right? I've got dense breasts, oh my gosh. But on patients that really truly have dense breasts, vasodoxifene can decrease the density on the imaging. So you don't see that same imaging density that you would if it was an estrogen and a progesterone. So in patients that you may have a high risk for breast cancer, so have patients with maybe had a biopsy of ALH or atypical lobular hyperplasia, or they have a family history, or they're really nervous about this. I mean, I think this is a good option. The problem is sometimes their insurance doesn't cover it, and it's expensive. I have patients that have had, BRCA mutations, and they're younger, and they've had their surgeries, but, looking for some type of hormone replacement. They haven't had a hysterectomy, which is another frustrating thing. Why do they take the ovaries out, but not take the uterus? And then they're going to give me a young patient and say, give her hormone therapy, and she's BRCA, 1 or 2 positive. So really irritating. Just take the uterus too. Anyway, the oncologists do that. Are there any oncologists here? Where's Dr. Span? Just take the uterus out too. And anyway, so this is a good option for those patients. Now, during COVID, I did have patients on this, and then they had a production problem, exactly, which was really, really problematic. But it is back in, I think it was a packaging problem or something like that. So it is back in, is available. And I think, we could look ahead to see, are there going to be other things developed where either you have vasodoxifene that's available separately, and then we can use that with maybe a patch or something like that might be kind of ideal. Just to review quickly, non-hormonal treatment of vasomotor symptoms, because this is definitely a lot in the news recently, and Dr. Reed just showed me that there was another report of another new neurokinin B antagonist trial that was reported yesterday. But fezolinetant was the one that kind of came out last year that is one of the recommended non-hormonal treatments that is making a big splash in the news. And then the North American Menopause Society last year did publish this position statement on non-hormonal treatment for vasomotor symptoms. And I mean, I like that they kind of did this like this, but I just don't like the way the column was like, not recommended, exercise, mindful, not relaxation. So it kind of, I mean, it's you got to do those things. They're just not recommended for vasomotor symptoms. But the way it reads, I was like, okay, don't read it that way. So there's two things that are approved by FDA for non-hormonal treatments of vasomotor symptoms, and one is the paroxetine, low dose, taken at night. It is, basically, paroxetine, and it can be expensive too. So I'll just tell you the truth. I just use 10 milligrams and take it at night, unless they want to take the brand name, and I think it works fine. And then the new kid is the fezolinetant, the neurokinin B antagonist that was approved last year. And their other one that was just, a trial was just published, was like elinzanetant or something like that. But there's several of these that are kind of undergoing trials now. So this is a picture of, don't you like to go back to organic chemistry and see what things look like? Maybe, maybe not. I do. I think it's cool. So this one works centrally. This medication works centrally on the, so it was found that women in perimenopause or menopausal women, when they did autopsies, they had this part of their brain that looked like it was kind of hypertrophied, and the quote candy neurons, kisspeptin and all that, I think was identified in the early 90s. And so this area kind of hypertrophies without estrogen and affects the thermoregulatory center in the hypothalamus, and that is thought to be kind of what causes hot flashes, basically. So, I mean, that's a major win to figure out what causes hot flashes. I mean, it took a bit, but, we finally got that going. So this medication is an antagonist. It binds to that receptor and helps prevent that hypertrophy and helps kind of with the regulation of the hot flashes. It was shown to be superior for decreasing frequency and severity of vasomotor symptoms. There were two trials, Skylight 1, Skylight 2. I still haven't figured out why there's no Skylight 3, because it's not in the literature yet, but there is Skylight 4 coming up here in a minute. But this looked at different doses. Prior to that, they looked at animal studies and all of this. I don't know how they measured that, but they did on the little animals. Oh, they're having hot flashes. But the Skylight trials, I will say, were, supported by the drug company that makes the drug. Just throwing that out there. And on these trials, there was also a considerable placebo effect in the reduction of vasomotor symptoms. So there you go. And this trial was done between, I think, July of 2019 to maybe January of 2022. So it did encompass COVID. So there's a lot of mixed up stuff in there with COVID. And so not uncommon that the most common side effect was headache, GI disturbances. There were elevations in liver transaminase levels that did return to normal after the persons were discontinued the drug. But interestingly, people on placebo also had elevated liver enzymes. So, yeah. It has now this warning that, to check the LFTs prior to use, and at 3, 6, and 9 months, it is taken orally, without regard to meals, and then, maintains a steady state within 2 days, so within like a couple of doses. It is metabolized by the cytochrome P450 system, which I have a slide here to show you kind of, there's lots of things that interact with that, so that's a little bit problematic. It is renally excreted, so if you have renal failure, not good for you to use that. And it is checked on GoodRx, over $500 per month, unless you get kind of the coupon from the company, and then, that lasts for a little bit of time, and then they want you to kind of keep buying the drug, so. So here are a list of things, drugs that kind of either inhibit the cytochrome CYP1A2, and so if they're inhibitors, then you'll have elevated drug levels, which is not good. And then if they're inducers, then you have lower drug levels, which also is not good. And there's just a lot of things in there that people eat every day, I would think. So, so the Skylight 4, so if you develop a drug to treat vasomotor symptoms in menopause, you have to show that it's safe for the endometrium, even though you wouldn't think there would be any physiologic way that this drug would interact with the endometrium. So this is the Skylight 4 trial. And so this trial also, the mean BMI was around 28. So I think the BMI was 18 to 30. For the other trials, the BMI was maybe a little bit, they had a little bit more. But anyway, this one had a little bit lower BMI. And, it's safe. There's not any endometrial cancer here. Sorry, here we go. But there was, kind of this same thing with this slight elevation. But see, the placebo has it too. Liver test elevations, we got placebo, as well as the different doses. The 45 milligram dose was chosen from all, all these trials were kind of going on simultaneously because it did show a little bit better results for sleep than the 30 milligram. So they both lowered severity and frequency of hot flashes or vasomotor symptoms, but the 45 milligram was a little bit better for sleep. All right, so here we're coming to the end. 48 seconds. I'm running. New therapies. So estetrol, which you may have seen or heard about because it is available in a birth control pill that was approved in April 2021. And and this is like the fourth estrogen that's been described, right? So, but made during pregnancy. And really interesting to think about, if you think about, the high hormone levels in pregnancy and how that one of these estrogens might kind of antagonize the others in the way that they affect the liver and possibly in the breast as well. So it's weakly estrogenic in the breast, and it's antagonistic to estradiol when you give those together. So I think that's really, really interesting. So it is being tested for treatment of vasomotor symptoms. I think the dose they're looking at for vasomotor symptoms is around 15 milligrams. Oh yeah, there it is, never mind, 15 milligrams. But it would have to be combined also with progesterone. So again, this may be something on the horizon that you see kind of coming out because you have lower impact on liver metabolism, lipids, all of these kind of negative effects that, or the stronger effects that other estrogens have, and possibly we'll look to see more about estetrol. So summary, we went through a couple of cases. Hormone therapy is definitely an optional option for the management of menopause symptoms. Definitely, you've got a personalized approach. I think that it is a safer option than it has been given press about, and that we need to think about the different types of therapy that we have available now, the different types of delivery systems that, probably I usually try to start with a transdermal therapy. And, depending on the patient's age and risk factors and all that, certainly if you're looking at osteoporosis prevention, then, the higher dose is better than the low dose. But maybe the truth is in between, where the patient wants to be for lowering their other risk factors. So in addition, please don't tell people that they have to come off their hormones at age 65. I see this all the time. This really needs to be to the internal medicine providers or primary care providers who always want to take patients off their hormones because anything goes wrong and they're like, oh no, I'm not going to give you that prescription. Go find your GYN. So I think that's it, and I'll take questions. So I've got references here for you. I wanted to just point out also patient information that you can write down. I send my patients to these references all the time, menopause.org, which is the Menopause Society website. And you too can get certified by the Menopause Society. I would encourage that if you're take care of these patients. I mean, that really, they have great information, and anyway, that's just a plug for them too. So, yeah, thank you. where's my testosterone plant? Because I have some more slides on testosterone.
Is there a particular IUD you prefer for endometrial protection in menopausal women?
Is there a need for endometrial protection?
No, is there a particular IUD you prefer?
Oh, IUD. So there's no FDA-approved IUD for endometrial protection for menopause, but in general, whichever IUD you can get in there. So sometimes if the patient is nulliparous and, wants to try an IUD and, she may have a little cervical stenosis, I'll go with kind of the smaller IUD. And then you can follow with bleeding, or you can follow with imaging to kind of see where things are. Yes. Sorry. Missy.
Hi.
Where's my testosterone?
No, I don't know that one. Thank you so much for this talk. It kind of follows on what you were just saying about like whatever IUD you can get in there. I noticed on your slide that the Nexplanon's not listed as a progesterone for endometrial protection. Theoretically, it seems like it should be okay, but just curious about your thoughts about that. And then if progesterone is the bad guy, do we have any data on etonogestrel and some of these outcomes?
Yeah, I don't know any, I really just don't know about the Nexplanon and endometrial protection, but that's an interesting thought.
Because then you don't have to go through the cervix.
What's that?
Then you don't have to go through the cervix,
Yeah,
you know?
I hear that, I hear that. I think the negative would be, well, is that still systemic versus local would be kind of the argument of, and sorry, that light is like right smacking here, okay. And then second part of your question, I'm sorry.
If you know of any data on the other outcomes, like if etonogestrel somehow impacts breast cancer in different ways.
Yeah, I'm not sure with the next month, no.
Awesome, thank you.
Yes.
Hi, I'm Joy Lumen. Thank you so much for that talk. I'm so confused about menopausal hormone therapy, like really, really confused. Because I feel like I'm not clear if estrogen alone increases the risk of breast cancer or not. I'm not clear if, like, what we support in terms of local hormone therapy for breast cancer survivors, like, is there a first line? Are we supporting estrogen? Are we saying Osphena should be first line? Because it's difficult for me to get Osphena approved, even though it seems like it should be the first option. And I'm confused about whether or not transdermal hormone therapy, particularly estrogen alone, increases the risk of blood clots or not.
Okay, so there's like so many questions in one thing. Okay, so first, I don't think, the first question was, you're confused about does estrogen alone cause breast cancer, or is it?
Increase the risk of breast cancer.
So, I think that it probably doesn't. I think, we can look at different studies. I think in patients that might be getting breast cancer when you've had a hormone therapy, then it might show up sooner. We're doing earlier and earlier screening for breast cancers. They can pick up things earlier than it would show up. So I think that's probably what's going on. And then you had, I think, vaginal for breast cancer patients for GSM. Oxyfenazine is not approved for use with breast cancer patients. So definitely I would go with local and local.
It's not, but it's a SERM.
What's that?
It's a SERM.
I know, but it's not been studied in breast cancer patients. I hear you that it would be something that you would think would be useful, but I think the local therapy is probably where I would go now. And I know there's been some controversy with some oncologists not being willing to agree with that, but I just try to convince them a little bit. In truth, I tell patients, you don't have to use the plunger thing or the applicator thing. When you're using the estrogen cream, just put a little bit on your finger here and just kind of put that around the vagina, just like you do your face cream. I say you got your face cream and you got your face cream. And in fact, some dermatologists do recommend estrogen cream for the face and for the wrinkles. So that was a presentation at NAM's meeting last year where the dermatologist talks about using the estrogen cream around the eye. So everybody then started using their vaginal cream on their face. And maybe their whole body. No, I don't know. Okay, and then there was another part to the question. I can't remember. Did I get them?
I think you hit them. The blood clot issue.
Oh, the blood clot issue. So transdermal estrogen is not been associated with blood clot.
Okay, so would you use transdermal estrogen in someone that has had a blood clot?
No, I wouldn't.
See, that doesn't make sense to me.
If they've had a blood clot, I mean, it depends on whether that was, was it provoked or was it, if somebody had a history of developing a blood clot post-op or post-surgically, and they didn't have any other genetic reasons to have a blood clot, then I might consider a low dose. If they were symptomatic and they were willing to, use it, then yes, I would.
But you'd use like Vioza or something else, just in case, for the most part.
What's that?
You would use something else. Like if it was for vasomotor symptoms and a patient had a history of a blood clot or had a heritable risk for blood clots, you would choose Vioza.
Yes.
Okay.
So you can use, in some patients I've used progesterone only as well, if it's vasomotor symptoms, and use the micronized progesterone, and that can be helpful for that. And now I just want to point out, the fact that you are confused about this,
I'm so confused.
then you can think where the public is. I mean, you are knowledgeable and you are, you know what I'm saying?
I do.
And I think that's the problem.
And I'm trying to make it make sense for them, and it doesn't make sense to me.
Yeah.
Especially the cardiovascular piece. If it decreases the risk of coronary heart disease and heart attack, why are we saying we shouldn't use it to prevent primarily? All of that just doesn't make sense to me. Yeah.
No, I hear you, and I work actually with our women's heart program who send me patients that if you don't have current heart disease, but you have a high risk, then she's like, yeah, let's get some estrogen on, let's get a patch or something going there. But the fact that you're having all of this kind of distress about understanding everything.
I'm so distressed.
That's why that we're going to lose the battle unless we can get a clear message out. And this is why, a lot of the little med spas and all this are they're taking these patients and giving them lots of other things. And so it's very concerning. I mean, I kind of feel like we've failed also with kind of the pap smear message. How many patients come in now and they're like, oh, I was told I didn't need a pap smear for 5 years. And then they come in and they've got, a vulvar lead. They got other stuff going on and they think they don't have to come in. So our messaging here has been not very good, basically. So, yes. I'm so happy there are so many questions.
Thank you.
I love this.
Thank you so much. I'm Desiree McCarthy Keith. I'm with Shady Grove Fertility in Atlanta. I'm also now postmenopausal patient, so I appreciate your talk very much. So I guess I'm the plant. Would you please speak on testosterone?
Oh, testosterone?
Yes.
Oh, I'm so happy.
Thank you.
Okay. All right. What about testosterone? What about testosterone? So, why hasn't this really been looked at? So it has been looked at a little bit for hypoactive sexual desire and has been shown to be helpful. But here's the problem. There is no FDA-approved testosterone for women in the U.S. So there are other countries like South Africa and Australia that do have testosterone that's improved, in an improved formulation for women. But because it's not available, then I think people are getting it from other ways, like pellets, which, pellets are not FDA approved. I'll just say that. They're not endorsed by the Menopause Society. And one of the problems with pellets is I think you have really high doses that kind of go in pretty quickly, and then it takes 3 months, and then once it's in, it can't come out. And I have seen patients that have had like really super physiologic levels of testosterone, like 700, who've had a pellet, and the max that you would want in a female is usually around 80 after menopause. So I'm not going to get up here to say poo-poo for the pellets, because I think people are really looking for other alternatives. And we don't have, we're not giving it to them, so they're going to other places. But there are concerns with testosterone. You got to look at, kind of lipid panel and all of that. And there are some studies that show increased risk of breast cancer with testosterone. So just, some patients who might not be candidates for estrogen, who have low libido, might want to use testosterone, have used it in that capacity as well, but there might be slight increases in breast cancer. And I think I only have 1 or 2 more slides. So the testosterone plant, thank you so much. You do have to monitor levels, and usually what I check is total testosterone. And you want to check it before starting and then, monitor a few weeks later, in addition to monitoring their response. And, then basically every 6 months, because testosterone is a controlled substance here in the U.S., controlled substance, like, you have to, they get your FDA number every time you prescribe it. And the way I use it is with a compounding pharmacy, actually, now. So that's what I do. And then I think it's important to check sex hormone binding globulin and lipids before, because if the sex hormone binding globulin is really high, then, your testosterone is not going to be as effective because it's just going to bind it up. Or you have the patient that's taking spironolactone and all this other for acne, and then they want to take testosterone. I mean, you got to kind of sort all that out as well. So, and then there's some references for testosterone. So I hope that answered your question.
You have time for one more question.
Okay, sorry. And I'm available later for any consultations.
So I'm Kathy Chance. I'm in Augusta, and I'm a gynecologic practicing physician only. I stopped OB a while back and do a lot of menopausal hormone replacement therapy in my practice. And I was just going to say thank you so much. I enjoyed pretty much every word you said. I also use testosterone and have done injections and pellets, but I do monitor and think that's a great idea. But what scares me the most, and this is mainly talking to maybe the younger people that are coming out of residency and are really worried about using hormones, is that those of us who are older are extremely worried about our younger generation of gynecologists. And I certainly don't want to make any enemies in the room, but I would encourage you to absorb everything that she said, particularly the slide that said that you reduce all-cause death associated with aging by 11% in both the estrogen and I think the estrogen and progesterone arms. I mean, Dr. Friedman, I don't know if any of you all remember him, but Murray Friedman has been here for many, many years, and I miss him every day. He retired from my practice, but he was such a proponent, and I learned almost everything I know about hormones from him. And it's hard, we don't get into residency, but I really encourage you to become proficient in hormone management. You guys have got to take the ball. You've got, when all of us retire in another 5 or maybe younger years, there's not going to be anybody left to do hormones. And I personally think it's extremely, extremely important. And don't be afraid of it. It's really not something to be afraid of. It's an awesome thing that we can do for the female population.
Yes, own it. Yes.
Can I please respond to that real quick? I'm sorry. Jennifer Allen, Medical College of Georgia. I'm in Augusta. I'm the resident CPD. I manage menopause. Thank you for this 1-hour lecture. As someone who teaches menopause, manages it, I know it's impossible to tell us everything in an hour. Kathy, it's my mission to teach our residents about how to manage this and make it better for this generation, because I graduated in 2014 and it was very minimal. And so 5 years ago, I was the confused provider going, what am I supposed to do with all these menopausal patients? The Menopause Society is a wonderful resource. They put on an excellent annual meeting every fall. I'll be there in Chicago in September. You should look into that. It's usually about 5 days. They even have like an intro to menopause first day. So for anybody who's out in the community practicing and they got to relearn or learn new things because they didn't learn it the right way the first time, if they were training in the WHI times, or if they've got to they're young and they need to learn how to do it right now. It's evidence-based, it's interdisciplinary, and I strongly encourage it. Just let this lecture be a springboard for where you want to go with your learning. Thank you.
Thank you. I totally agree.
So a couple quick reminders, please stick around. We're going to have the business meeting quickly after this. Also, junior fellows and med students, please don't leave. Meet at the back in the hallway for pictures. But right now, we have a surprise guest. Our next guest leads initiatives and advocates for the passing of legislation to combat human trafficking and support youth victims on sex trafficking. And although she was not able to join us in person during this conference, she's recorded a special message for us. Please welcome Georgia's First Lady, Marty Kemp.
Hello, I'm First Lady Marty Kemp. I hope you're enjoying your time on Georgia's beautiful coast. On behalf of a grateful state, I want to thank you for all you do to promote the well-being of women across Georgia. Every woman is someone's daughter, sister, mother, or friend, and your work ensuring their health touches the lives of all those they come in contact with. We know there is still more work to ensure we are meeting the healthcare needs of patients. That's why, for example, the state increased funding in this year's budget for DPH's maternal health pilot program in rural areas. I want to encourage you to keep working to support those in your care, and thank you again for all you do. Enjoy the meeting, and God bless.
Okay, so that brings a conclusion to our meeting. We are going to move on now to the annual board meeting. For those of you that are GOGS members, please